Good afternoon. My name is Amnon Gavish, and I'm coming from a company called Video. And I'll talk today about video-enabled telemedicine solutions. I'll be very practical, so it won't be a lot of marketing fluff. I'll talk about real-time and real-life examples and what are the considerations in actually going and deploying this kind of video-enabled telemedicine points of care. I'll start by defining the problems, and then I'll give three perspectives. I apologize in advance. The first perspective is going to be a little technical, less medical. I'll try to run as much as possible through it, and then talk about the physician perspective and the patient perspective as well. So what is basically the problem that is around there? Well, video conferencing has been there for, people say 40 years now if you go back to the AT&T video phone, and for many years also in healthcare. But it was really limited. It was confined to within the hospitals. It was a hospital to hospital, a video conference room to a video conference room, and always within a managed network with a very limited setup. So the question is, if you really want to go out and provide telemedicine to the masses, you have to go outside of the confines of the hospitals and being able to reach to rural areas, to remote clinics, anyway to the one or two doctors' remote clinics, and even beyond that further to at-home patients. And people talked about readmission problems. You send a patient home, you have no idea what's going on there, unless you really have an eye that you can talk with the patient and see them regularly, as well as going out to support groups, being able to bring together patients, caregivers, and patients without having them transported to the healthcare institution. So the question is how to handle this kind of expansion, how to extend the reach of video conferencing as a major tool in telehealth. Well, first of all, what does it mean? It means that we have to use whatever that is already there. We cannot set very expensive IP connections to homes of patients, even not to clinics. And we cannot put very expensive, very impressive telepresence systems in every patient's home, or not even in the doctor's home. It's not scalable. It's not economical. So you must leverage the free and cheap IP network, whether it's a 3G, 4G, the broadband connection that people get to the homes or that remote clinics get. The other thing is it needs to be available in whatever platform people already have there. Since you're not going to install at 10,000 patients at home very expensive video conferencing equipment, you would like to use whatever they have. So what do they have? They have computers and they have mobile devices. So the solution has to be something that can allow you to provide a very low cost and efficient, simple to use solution. So let's take the headache of the network provider. So what the network provider needs to keep in mind? He needs to keep in mind that he's going beyond this protective area. It's not the QoS network that he has in the hospital. He has to go out there. And out there, it's the wild, wild west or east. It's meaning everything can be out there. Firewalls, other problems, network going up and down, whatever. So, and you have to live with that, and you have to deal with that, and you have to actually provide a reliable connection and a meaningful interaction between the patient and the physician in these conditions. So you need to run on non-QoS networks. You need to use, as we said, the existing infrastructure that everyone has, because if you want to go large scale, you need to go with the consumer infrastructure that is out there. The environment is not homogeneous anymore. I'm coming from the US, and I've seen that one of the major issues that health IT has there is that every doctor has his own device. They don't get the device from the hospital. They get it from the service provider. So one has iPhone, the other one has an Android, one is an iPad, the other one is a Samsung Galaxy, and another one is a netbook and a Mac and a PC. And everyone has their own stuff, and they want the access to this using their device that they're using every day because that's what they're used to. They don't want to carry two devices in their pockets, one for work and one for whatever they do otherwise. And that is also important for the next point because you would like to be able to access the point of care from the physician side as well as from the patient side anywhere you are. You don't want to have to go into a dedicated place in order to have this kind of interaction. And you'll see one of the doctors providing a testimony later. He's actually doing consults from his car on a 4G card. He stops at the side of the road, pull out the 4G card, connect to an iPad, and do it in a teleneurology consult. And to do so, you actually need to have something that is capable of working on whatever you have in that point of time. The other thing, a very important point, is how do you manage that? How do you manage 100,000 patients or 1,000 doctors within a network that provides this kind of solution? You need to, I think people talked about the need to schedule. The need to have resources available. You need to actually log and document the sessions, either for reimbursement purposes or for follow-up purposes. So there is a need to include a process management system integrated with the video solution. The answer comes with, it's a very, the buzzword of the world now is cloud. So the answer comes if you can actually have a real cloud-based video conferencing infrastructure, you can provide this kind of requirements. It means that the service should come on some kind of converged IP network that can bring together anything from the regional hospital to the rural clinic, to a satellite facility, or people that are coming from their home office or the living room on the public network, and bring all of them together over a cloud-based solution that can have the flexibility to provide resources ad hoc or scheduled, can adapt to the non-constant conditions of the network that can fluctuate very significantly, and can provide error resilience. So you actually do not break in the middle of a consultation. Everyone that has been using video conferencing before is familiar with the blockings that you see, all the artifacts with the green and gray artifacts that make the other side look more like a Picasso picture more than a living person. That actually affects very significantly the user experience. It's not natural anymore. So you need to avoid this kind of artifacts. And, as I mentioned before, being able to access the service on any kind of form factor or devices. So you need to have all the variety, from the smallest form factor on a smartphone through the tablet form factor, which is very, very common now within physicians, through PCs, all the way to the telepresence room systems that are, can be installed in big conference and surgery rooms. So a few words about the integration into the management or the management process. I picked up an example of a telemedicine management system from Ontario Telemedicine Network in Canada. And here, basically, the video conferencing is not anymore a separate, siloed system that you have to go and start it. It's integrated completely into a scheduling system that allows you to schedule in advance a meeting. The meeting will allocate the resources, being the physician, the nurse, and the patient. At the time of the meeting, it's just a single click, and the meeting occurs. So there is no need for anyone in the conference to think specifically about the video interaction. It's the equivalent of just walking into the room or into the examination room of the physician. So that's also a burden on the network provider. How do I make everything, all the flow control of this kind of a large-scale deployment of virtual examinations? Here's another example of the network consideration. This is a flow of a telestroke program within Massachusetts General Hospital in Boston. Basically, a patient with stroke symptoms is going into one of the remote hospitals in New England. There is no specialty there to provide and administer the right treatment. They go on a video conference into a specialist, a neurologist out of a Massachusetts General Hospital. If needed, that specialist can also have a third party joining in for a second